Welcome to Doctor, the radio show and podcast featuring your physician hosts, Dr. Tom McGovern
and Dr. Andrew Mullally, where we and our guests discuss relevant health-related topics from an authentically Catholic perspective.
Today our guests will be heard across the EWTN Global Catholic Radio Network. They are Deacon Dr. John Traveline and Sister Dr. Mary Diana Drager. They're assistant editors of the Linacre Quarterly, the Catholic Medical Association's 87-year-old Journal of Morality and Medicine, which is the oldest medical ethics journal in the United States. And they will do so regarding the November 2019 special issue on the topic of brain death.
Yes, I'm very excited to go through this interview, especially with these guests, because they are so measured and so well-rounded, being both ethicists and physicians.
And this interview was performed in late September 2019 in Nashville, Tennessee at the annual educational conference of the Catholic Medical Association, where over 900 people, the vast majority of physicians, attended and had a tremendously good time and even learned something medically.
That's right. And so we want to kind of set the stage for this interview because this is a hot topic. It's a controversial topic, even among well-intentioned Catholic physicians. So we wanted to kind of go through a little bit of the history of brain death.
And, before 1960, death was defined simply as complete and irreversible stopping of heartbeat and breathing.
That seems pretty cut and dry.
Very cut and dry.
I think a child would agree with that diagnosis.
Yeah, they'd hold the mirror in front. In fact, I think they still do that when popes die. They hold a mirror in front to see if it gets fogged up or not.
Right. Okay.
So the concept of brain death was introduced in 1959 by two French physicians, and this came about because of the need for organs for transplantation
and the discovery and the usefulness, basically, of artificial respiration.
Well, right. That's an excellent point, Andrew.
Because before that, when somebody couldn't breathe, you can only do CPR-like strategies for so long, and then they pass away. But now, when we put someone on an artificial respirator or ventilator, we can keep the breathing going and the blood flowing for quite some time.
Yes, that's a great point. And you're going to hear Doctors Drager and Traveling talk about this 1968 report that came out of Harvard Medical School, where they defined brain death as a state of irreversible coma, and where there is no spontaneous respiration during a 3-minute period, and where certain brainstem reflexes are completely absent.
And so that is a pretty good idea that the person has died. All dead people would pass that test. There is kind of an area that we're going to discuss today where it's not that clear cut. But from where they were looking at 1968, that's not a bad place to start. The only thing that I found really interesting was for a scientific position, something out of Harvard, very official, you'd think that it'd be full of footnotes and lots of evidence. It wasn't, was it?
How many footnotes, how many references were there?
There was just one, to my knowledge.
And from which scientific journal did it come, Andrew?
This came, believe it or not, from a Catholic pope, Pope Pius XII.
Yes, a comment about.
So that was the footnotes that they were hinging this basically position statement on.
They were just making it up out of thin air, almost. But that report in 1968 unambiguously proposed that brain death should count as death. And it's, even at the time, there was a lot of pushback against it where they said that brain death does not disrupt the integration, the unity of the body, that heart and lungs were a measure of that, but that the brain alone was not. And that debate continues on today because we're trying to bridge a philosophical reality, that is a separation of the soul from the body, with a medical reality which cannot measure the presence of the soul.
Right. We don't have a good test for soul is present, yes or no.
And I love this. I watch Star Trek reruns with my 13-year-old twins, and in there, their philosophy and theology of death is really poor. In fact, my twins look at me and they hold their noses because they will say, death is the time when you only exist in the memory of others. And my twins are like, no, that's not. Death is when the soul and the body separate. Yes, thank you, twins. I'm so happy that you understand that. And much of our society, sadly, does not.
Right, and I think that's, one of the things they definitely don't teach in public school, and even a lot of folks are never exposed to the idea of philosophy and the idea that you can really know things rationally apart from empiricism and things that you can feel, touch, and measure.
And what is empiricism?
Kind of things you can feel, touch, and measure.
Okay, that's all it means.
And,
yes.
And kind of the idea in our tech and science-driven culture that what is knowable has to be provable in some way and measurable. And philosophy doesn't operate in those terms.
No.
It operates by rules of reason, and it really appeals to the idea of a natural law that's imprinted on all of our hearts.
Right. So scientific method is good for measuring scientific things, but not all things are scientific.
And you can appreciate how doctors or scientific-ish people in 1968 neglected potentially some of the philosophical conundrums that this brings on.
Yes, but it was primarily transplantation programs with their need for the freshest organs possible that led to reevaluation of the concept of brain death, such that some consider death of the brainstem as death of the brain as death of the body. So you're trying to focus the essential aspect of the body, this little part at the bottom of the brain above the spinal cord called the brainstem.
It does. It makes it tough because if the soul leaves the body, at what point can you obtain a living heart or living lungs from a dead body?
Right.
Which is kind of the question. And it's hard to explain to a child. It's hard to explain to me. And so hopefully we can delve into that a bit.
Yes, and our guests will do that, as you will hear. But you will notice that even among neurologists, among doctors in different countries, there is not a unanimous opinion. There is not consensus that absence of brainstem reflexes means death, let alone brain death. In fact, in Europe, they have a different concept of brain death than we have in the United States.
And even institution to institution sometimes can have different rules about determining brain death.
Yes. And so how many patients might slip through the cracks?
And that is what inevitably brings up stories that people have seen or heard in the news where someone was declared dead and came back to life. Well, that is done differently in different places, which it seems like that would be standardized, but that is one of the problems that we're facing.
And now in the country of India, it has become necessary by government law that anybody who dies from brain death, the government must be notified right away to get more transplants available. But in this article out of India, this neurosurgeon says that because of laws, an individual could be considered legally dead in one country but alive in another country. Imagine that.
Yeah, that is a challenge. And here in America, in general, we work with the idea of whole brain death. That was determined in 1981 when the Council on Bioethics wrote a paper regarding that. That's applied differently in different areas, but in some countries, as Tom was alluding to, part of the brain can still be totally functioning as long as the brain stem is dead.
Right.
We don't have those rules here in general.
And a piece of data that I looked for and found after the interview was what percent of people declared dead in the United States are declared dead by brain death criteria. And I found it, and it's 1 to 2% of all deaths are brain deaths.
That's a lot.
I think so. I was guessing it would have been less.
Yeah, that's a big number.
So even though practice parameters were published in 1995 in the United States, updated in 2010, there's still disagreement even within our own country. Well, you'll get to listen to Drs. Drager and Traveline. I will pose the medical trivia question of the day. Well, since the criteria for brain death were developed because of the need to preserve organs for organ transplantation, and yet so that we had moral certitude about the death of the donor, this episode's question will deal with organ transplantation. So it's a two-part question. Number one, how many organ transplants do you think were performed in the United States last year, in 2018? And the second question, which I find to be even more fascinating, what percentage of American adults are signed up to be organ donors? We'll be back after the break with this fascinating discussion with Drs. Traveline and Drager here on Dr. Doctor. Welcome to another special interview of Dr. Dunn in Nashville at the 2019 Annual Education Conference of the Catholic Medical Association. We here are going to be tiptoeing and trying to give some good information on a very challenging topic, the topic of death. Death is a challenge for a number of reasons, and we're going to talk about a concept called brain death. This is going to be the topic of the upcoming issue of the Linacre Quarterly, the official medical moral journal of the Catholic Medical Association. In fact, the oldest medical moral journal in the United States. It's been published since 1932. We have with us today two of the editors of this issue. First, I'd like to introduce Deacon Dr. John Traveline, not new to Dr. He's spoken to us twice before. Deacon John, would you please tell us why you are one of the right people to talk about this?
Tom, thank you. It's nice again to be with you and to speak about yet another important topic. My involvement with this issue comes because of my role as the executive editor for the Linacre Quarterly.
And also, you deal with a lot of people at the end of life in critical care, do you not?
I do. I practice intensive care medicine, critical care, and pulmonary medicine at a large transplant center in Philadelphia. And so these issues surrounding death, these issues surrounding brain death are close to me in the clinical realm.
And our other guest today is Sister Dr. Mary Diana Drager, OP of the Nashville Dominicans. Sister Mary Diana, why are you here with us today as one of the experts to help unpack this a little bit?
Well, I wouldn't say, Tom, exactly I'm an expert. However, I am the chair of the Linacre Quarterly Committee at the moment, and so work very closely with Barbara Golder, our editor-in-chief, in order to develop the content, strategic goals, and things like that related to the Linacre Quarterly.
What would you, before we get into the subject, like listeners to know about the Linacre Quarterly?
So the Linacre Quarterly is the official journal of the Catholic Medical Association. We publish 4 times a year, and in the November issue of each year, we cover a specific individual topic of interest to our readership. So, for example, last year, which was the 50th anniversary of Humanae Vitae, our issue was related to Humanae Vitae. In past years, we've had issues related to the elderly or issues related to women's health issues or issues related to social teaching of the church and how that interfaces with medicine. So each year we run one special issue in the November issue and focus on a particular topic.
So why did you choose brain death for 2019?
This topic of brain death has been something in our organization, the Catholic Medical Association, for a number of years, with many people discussing this and wanting to move in the direction of bringing some clarity, speaking to the extent that we could authoritatively as physicians speak to the medical science of this entity, this diagnosis of brain death. So it's something that's been swirling for a few years, and as we were thinking about a special issue topic, this rose to the top.
You know, Deacon, I'm thinking that many of our listeners would probably view death as a binary issue, black or white. You're either alive or dead. And that's certainly how I had always viewed it until you get into caring for these patients that, you know, as medicine's advanced, there is an area, a kind of twilight zone where we are learning that it's not black and white. Can you describe to us what is death?
Well, I think before I get to that, I think it should be stated, lest there be any confusion about it, but one is either dead or alive. So in a sense, it is binary. I think what comes out surrounding this issue is an understanding of what is death in terms of how do we want to define, or how it is defined or has been defined. Or
So the question is we don't know exactly where that line is, but there's most certainly a line.
Yes, I would say absolutely there's a line. A person is either dead or alive. As we get into the clinical realm and as it falls in really not just our society, but I think societies in general across the world, it falls to physicians and those primarily to, quote, declare someone or to pronounce someone dead, if that's the case. And we've been guided by through the years, at least in modern medicine, the time-honored definition of death clinically that a physician could use was when there was irreversible cessation of the heart and breathing function. So a person who had no pulse and had no spontaneous respirations could be declared or pronounced dead.
So I think an important distinction here, too, is that there are two different concepts. One is the person is dead or alive, but then there's a separate concept, and the Vatican or the Pope has talked about this at times, and that is that there are signs that, in fact, this has happened. So death and the signs of death are not exactly the same thing. Exactly. And so that's where the distinction has to be made. So classically, physicians have identified death as cessation of function of the heart and the lungs, and so we look for signs that in fact has happened. But it's not that the heart stopping or the lungs not working, that is not death. Death is actually a metaphysical concept, right? It's that the soul is no longer animating the body. So we consider the person to be this perfect unity of body and soul. The soul is the animating principle. The soul is the form of the body, we say. So death is when the soul is no longer animating the body. And the question is for physicians to identify the signs that in fact has taken place.
That really helps to clarify things, Sister. Around these difficult questions, what is your hope for this issue of the Linacre Quarterly?
So the hope is that we can perhaps continue some really good conversation, because I think a lot of people have many questions about this. There are some people, some very, very strong, good Catholics who have absolute understanding of what brain death is, and they believe that it is clearly a sign of death having taken place. And there are others who have questions about this and don't think that we've really crossed that divide between the metaphysical understanding of what death is and the medical science statement of what are the signs that in fact this metaphysical concept has taken place. And so we know that within the Catholic Medical Association, and even for that matter outside the Catholic Medical Association, people have questions about brain death that they feel haven't really been answered yet. And so we looked at this issue as something that's perhaps bringing some of these more of these questions to light. In fact, I think we actually ran across more questions as we went along. And we think that this kind of conversation is actually very important to continue. So our hope is continuing the conversation in a way that's respectful of both the philosophical and theological side of things as well as the medical and scientific side of things.
Well, that's a good place for a break. We'll be right back with more here on Dr. Doctor. Here we are back with both Doctors Deacon John Travaline and Sister Dr. Mary Diana Drager.
I wonder, as we kind of delve into this, if Deacon, you practice in the ICU, could you give us a clinical story that illustrates why brain death...
Or better yet, why is this relevant?
Why is it relevant?
Yeah, to our listeners. Why should they care about this?
In modern medicine, with the ability and the continued ability to address a variety of serious critical illnesses in patients, we have the ability through technology to maintain life of a person. Yet there are times when it appears that a patient is not survivable, will not survive despite all the applied technology to that person. And then these many times are the situations where questions are asked: could this person perhaps become an organ donor? And then the whole matter of declaring the person, pronouncing the person dead based on neurologic criteria, so-called brain death criteria, comes up. So it's a common clinical entity, and many people, many families are faced with this, unfortunately, in these often tragic circumstances. So,
Deacon, you had mentioned organ donation. Is that a main reason why we are worried about brain death, or do you think it would be a clinical issue in its own right?
I've come to really think that the development of this neurologic criteria for death really arose because of advances in transplantation of vital organs. So it was seen there was a need, so it seemed, for the ability to, as we say, it sounds like a crude term, but to harvest vital organs from persons once they were pronounced dead. And I really think this is a big part of why the neurologic criteria, brain death criteria, emerged.
And there's something called the Harvard criteria that kind of kicked this off?
Yeah, there again with technology sort of in the mid 20th century, the ability to keep people alive on respirators, for example, and cardiac life support systems. Physicians, philosophers, moral ethicists began to wonder about the end of that and what was really being done here. Coincident with those technologies to keep people going on life support systems, coincident with that time were developments in vital organ transplantations, heart transplantations in and around that time, for example. And I think the intersection of those things that were happening in modern medicine led to this assembled panel of experts that met at Harvard and came up with specific criteria for which specific criteria which could be applied to a person in this state. There's an extreme state near death being sustained with life.
And this was in 1968?
In 1968, the Harvard criteria were published in the Journal of the American Medical Association.
And have those criteria changed over the years?
For the most part, there have been modifications of that, and there's a lot of variation in those criteria from institution to institution, even country to country.
So even in secular medicine, there is not consensus on the exact criteria. Is that what I'm hearing?
There's general consensus. Sister, if you may want to comment to that, there is general consensus, but there is variation.
It seems that it's pretty much a statewide determination that individual states may have particular protocols that they are following, and even who can actually identify the patient as deceased by neurologic criteria. So, for example, in one state, that it can actually be a physician assistant who actually applies the criteria, and that's all that's needed. Whereas in other states, it has to be two independent neurologists, so physicians actually train for that, and many criteria associated with how that is actually done.
Well, let's give our listeners kind of a feel for the landscape. Out of 100 people who die in a day, how many would be declared dead by brain death criteria? Is it a really tiny minority? Is it less than 1 out of 100?
I would. It's clearly a minority, and I would say I would speculate a rather small minority.
Less than 1%, more than
maybe around there.
Okay.
Yeah.
Fair enough. So, can you at least couch in terms for a lay audience what some of the general criteria involve? What does it mean for a brain to not function or to be dead by brain death criteria?
They do some testing, right?
Well, in general, it's the criteria involve, for example, first of all, being clear that there's not some other conditions, commonly, for example, drug overdose that may mimic a state of no brain functioning. So making sure, for example, that that's not the case, making sure that the person is not profoundly hypothermic, another clinical...
Low body temperature. Yep.
Correct. So putting into place these sort of safeguards, so to say, and then both physiologic and anatomic imaging of the brain, a CAT scan, a blood flow study, perhaps a MRI
do
scan
they do
of the
the
brain
EEGs to check for brain waves?
EEG is many times done. It's actually one of the lesser reliable tests. It's just not as clean, so to speak, clinically as for example, a cerebral blood flow scan. Or a cerebral angiogram looking for blood flow specifically in blood flow to the brain. So these are part of the criteria.
So there's several
for establishing
very technical things.
They are very technical. Physical examination, we must not forget to ensure that there's no brainstem, or to assess whether brainstem function exists.
Can you explain to our listeners why brainstem function is important as part of this question?
Well, brainstem, we talk about brainstem in the conversations and discussions about brain death. Sometimes we'll hear the distinction between whole brain criteria, whole brain death criteria versus limited or less than that. And with whole brain criteria, what's being referred to there is that the brainstem, a more primitive part of the brain, for example, is included in that analysis or that determination of brain death.
So this part of the brain really controls like heart rate, breathing, but not rational thinking.
Correct. These are more basic reflexes of the brain. Eye blinking, for example. We talk about like gag reflex. We talk about other so-called cranial nerves that are involved that need to be tested for.
So there's a lot of technical things that go into determining this, so it's definitely not something that's applied lightly, but it does vary in place to place. So they might be applied differently in different countries.
It certainly isn't applied lightly, and as we were talking about the change or the uniformity in the brain death criteria, I know the hospitals I've been to actually have their own quote brain death policies. So even at that local level, there are very specific criteria that again are largely uniform, but may have nuanced components for the assessment of brain death.
That being said, one of the things that did come up as we were developing this issue for the Linacre Quarterly is that on a couple of occasions we had physicians note that when in particular institutions, they sometimes had to sort of go back and put things into place to be sure that the brain death criteria were being followed very closely. So perhaps there have been occasions when maybe the criteria have not been followed quite so closely, but the medical community has sort of expressed their own concerns about that and has tried to put things into place to make sure that protocols are followed very carefully. And we're actually looking forward in the Linacre Quarterly to having a little article about that written by one of our Catholic Medical Association physicians who can sort of explore that for us a little better and help us to see how that kind of process is managed.
So one of the big questions debated by authors is, official church teaching on brain death. Is there official church teaching?
So that depends who you ask. And once again, you can get some very good Catholic physicians and even theologians who will say that the question has been definitively answered. and others who will say that it has not been definitively answered. So it's a very challenging, that in itself is a challenging point. In fact, for this issue of the Linacre Quarterly, we were very much hoping that somebody would submit an article that really would take apart that whole concept of what's a magisterial teaching, or and more specifically, what's an infallible magisterial teaching. So unfortunately, we didn't have anybody take us up on that. We did ask specific people to write that article for us that would help to explore that. As I said, people had varying thoughts on it. It is true that Pope John Paul II had made some statements related to the issue of brain death. It is notable that his statements never appeared in something like an encyclical. It actually is not covered in the Catechism of the Catholic Church. So there are some very key documents, key teaching documents of the Church, which do not contain any kind of information on this issue. What most people refer to is an address that Pope John Paul II made to a meeting of transplant surgeons. And so different people will put different levels of importance on that statement. And I would say that, and some people point to the fact that the Church, that the Holy Father used some very careful language, it seems. So, in fact, he used the expression, "it seems that," in the process of
making his
And he was
a professional philosopher.
Yes. And what he was talking about specifically was that it seems like the signs of death that physicians are presenting to us, that science is presenting to us, do not seem to conflict with an understanding of a Christian anthropology. The Christian anthropology is what we've been talking about here, like in terms of like the metaphysics, like what exactly is life, what exactly is death.
And what is a person.
Right. And so the Holy Father, some people will say that statement was a magisterial approval of the brain death criteria. And some people will say, well, it's an approval that's a bit conditional on the science and what is understood so far. And that seems to be the key statement that people will argue as it either being magisterial, and then they will equate it with sort of an infallible teaching, and then other people saying that's not really a statement that would qualify as magisterial per se.
It would probably be fair to say that there's a paucity of statements in regard to brain death.
And not very many of them either.
I think that's true. The other statements that are made or have been made are actually statements out of a pontifical academy. And now pontifical academies are consultative bodies to the Holy See, and they are not official magisterial entities in a sense.
Like
although
a study
some
group?
people will, a study group is a good way to think about it. Yes, although again, some people will put a higher level of importance to that as well, and there's some very good people who put a higher level of importance on that. So it becomes difficult to really tease it all out, and that's why again this issue of the Linacre Quarterly we thought was so important is perhaps to bring some of these questions to light. And we are looking forward, we hope, too, to this being an ongoing discussion in the Linacre Quarterly, and looking for some people to perhaps write some of those papers that we didn't get yet.
Well, and Sister,
Hint.
before we move on, what year was it, or in about what year did JP2 make those statements? Was that some time ago?
It was around the year 2000, 2001 that the address to the transplant surgeons
I'm just wondering
was
in
done.
regard
Right.
to even our scientific information we have now, if when he made those.
So we have almost 2 decades of advances.
Right, and he clearly put the onus on physicians, on scientists to help with this. And so that's one of the points that people have made, is that if we have new scientific evidence that perhaps provides us with some different information, well, the Church is certainly going to be open to that. And so that's why we see that this conversation really does need to continue.
What are the top arguments supporting brain death criteria being medically and ethically appropriate?
To establish the clinical signs of death by using brain death criteria, then open the door for vital organs from that person to be used to the benefit of others.
And a vital organ is basically something, if removed, the patient will die.
Would die, right. So
Because if you remove a
heart-
kidney, patient's not going to die.
Correct. We talk.
If you remove part of a pancreas, it's
Correct.
yeah.
We talk of living donors,
Right.
or
Bone
living
marrow.
donors, bone
Living
marrow,
donors.
kidney, classic examples. But to remove someone's heart, obviously,
Right.
lungs, both lungs, liver. So, so the argument for, and I think is a very, very valid and a very good one, is that the benefit to be gained through ongoing advances in organ transplantation are huge.
Are there other arguments, or is that the primary one?
So I think one of the primary arguments is that the brain is seen as the integrating organ of the person, of the body, and without the integrating organ, then clearly the body cannot go on living. So that's kind of a key piece, I believe,
Very
to the
good.
argument. And so if the brain, in fact, is quote unquote dead, if the brain is not able to function as a whole, then therefore that's being seen in these new criteria, or these criteria that are 50 years old now, of the reason for being able to say that the human being is dead. Now you have to remember our language here. You know, we keep crossing back and forth here between scientific language and philosophical language, and we're
Right.
kind of pretending like it's all the same, and it isn't. The word person is not a scientific word.
Correct.
It's a philosophical or theological word that really is developed out of the whole concept of the Trinity. It's the way we were able to understand the threeness in the oneness of the
Yes.
Trinity.
The three
is
what and the
to-
three what else.
Right.
Yes.
The
one what,
the
yeah.
word person. And so from the point of view of humanity, the human person, again, in a sort of Catholic or Christian theological and philosophical terms, is the union of the single organism that has a unified body and soul. Now, that's not a concept in science, right? So
No.
person isn't really. In fact, there are multiple theories going around these days of what personhood is. Personhood qualifies in different circles on many different things. It's
Yes.
even if you're wanted or not is one of the criteria that
Right.
some people will say qualifies you as a person or
The
not.
whole abortion debate.
Right. So we're talking here about whether a person is alive or not, and yet person is not the scientific term, right? So the scientific term at best we could say maybe human being. And so from the scientific point of view, an integrated human being, to say that the integrated human being is alive, requires the integrating organ, which is seen as the brain.
That's very helpful. So we've just given. Did you have another supporting?
Just to answer the rest of that question, on the downside, the arguments
That's
against.
what I was just going to ask.
Okay,
Yes.
I think on the negative, those opposed to a brain death criteria is the danger. I think this was probably the greatest argument against it: the danger of seeing the body, seeing the person. The comments by Sister notwithstanding, that as in a utilitarianistic sort of way, as something, as an object to be used,
Right.
yeah, even used for good, and that's obviously very problematic. So that would be the major argument, I would say.
Would
or one of
another
the-
argument against it be that in some places where the brain death criteria have been applied, a person has actually regained consciousness?
Well, there are cases of this, but my I would caution that in these cases where people were, quote, declared brain dead, but then regained consciousness or some higher level of functioning, I would say these were misapplied criteria. They were improperly applied, faulty applications.
And again, that kind of points to one of the difficulties that we run into, is that when people identify that, person X was identified as brain dead and then they came back later on, is that some people will say, well, clearly the fact that they came back later on, that they are in fact alive, is actually evidence that the brain death criteria were not applied correctly.
Sure.
Whereas other people will say, well, evidence has it that they really did apply it correctly, if we're to go back and read the chart and believe what was written in the chart. And then, so maybe it really was applied correctly, but it's evidence that the criteria are not right. This is a big question. We don't really know which way it really falls out in this sense.
Well, and sister, I mean, I know we keep going back between philosophy and science. I've got kind of a more philosophical question. How can you remove a living heart or living lungs from a dead person?
Right. So I think the distinction that's being made, at least on the scientific point of view, is that an organ is not the same as an organism. And I think there are many Catholic philosophers and theologians who also make that distinction, that an organ is not the same as an organism. So the organism is the whole, and it's the integrated whole, whereas an organ individually may be able to survive the death of the person as a whole.
I've heard of the concept of what you were saying, the organism as a whole rationale for brain death, or the brain as a whole. What does this contribute to the debate about brain death criteria?
Well, I think it's important to, at least with respect to definitions and criteria for brain death, to consider the whole brain, the cortex, as well as the brainstem, as I was saying earlier. I think that's an important distinction.
And the brain death criteria do that? Do they
the
look at
whole brain death criteria?
Okay.
And some brain death criteria would not be whole brain, right?
Correct.
Very
so
good.
some do, some don't.
Yeah.
So
That's
it is
incredible.
an important concept.
Yes.
So, a key emotional type of question I have for you is, how were your beliefs, thoughts, feelings changed by all the different submissions and discussions you've had over this issue?
For me personally, professionally, this issue and reading the papers as they were coming in and continuing to think about these issues again as I practice in a transplant center and see patients, critically ill patients, it just stirred up a lot of questions in my mind. It took me deeper. I thought this, for me at least professionally, for many years of my career, was a established sort of issue, and I really didn't pay it much attention. It was, but through this issue, it allowed me to dive deeper into some of the concerns as it related to the whole use of the brain death criteria.
Yes, I would say too that it developed lots of questions in my mind as well. Not necessarily questions that would even argue against particular parts of how brain death criteria are determined or written. Some of it just had to do with bringing to light, and I think the importance of bringing to light how some of this has come about, some of the history behind it. So, for example, we were able to pull up the first paper from the Journal of American Medical Association on the consensus statement from Harvard. And one of the things that surprised us all was that we are in the year 2019, we're used to the idea that a consensus paper in a scientific journal, a major scientific journal, would have at the end of it probably pages of citations, of references to previously written scientific papers. And this original paper has no references at all to any scientific papers. It does have one footnote at the end of it, and the only footnote is actually a footnote to Pope Pius XII. Okay, now this is the Harvard criteria written in the Journal of American Medical Association, and the one footnote it has is to Pope Pius XII and his discussion about ordinary and extraordinary care. So that was pretty interesting to us, and it left us with lots of questions as to, well, how did this consensus statement develop? Because it's hard to kind of trace it down historically. In fact, there are secular bioethicists, apparently non-Christian and not Catholic, who have actually made this point, that the consensus statement that was derived in 1968 was really a bit arbitrary. and have even asked questions of, or perhaps no, they're not quite so concerned as to whether the criteria are valid or not. But they note sort of offhandedly that maybe it wasn't as scientific as we think it was. I mean, it's hard to really to tease that apart, and so it does leave you with those questions. And there were other questions that came up relative to other papers. So, for example, one person brought to light the fact that how brain death criteria are done in Great Britain, and pulled up an official document that explains some of that. And as we tease that apart, we realize that really brain death criteria in England, it's brain stem death is what they're talking about.
So that would be the whole brain.
No, not the whole brain.
Oh,
They're
not
making
the
the
whole
assumption
brain.
that
Okay.
perhaps that because the brain stem is also involved in part of the system that generates consciousness in the upper part of the brain, that as long as you identify the brain stem as dead, then that's really sufficient.
So you can assume everything above it is dead.
That's basically what they're saying. But it brought the question to light of if the let's say if the Pontifical Academy in Rome is talking about total brain failure, well, do they mean what we mean in the United States for total brain failure, or do they mean what's being stated in Great Britain? And I have no idea what any other country says about any of this. We didn't look at any other countries either. So I think there are lots of questions out there that have really provoked our interest.
I think something we need to make crystal clear for our listeners is that the Catholic Medical Association does not have an official position on brain death.
Yes, that's a very important statement. And we do know that going back at least 10, maybe 20 or more years, some of the members of the Catholic Medical Association have wanted us to actually make a specific position statement or position paper from our organization on this issue of brain death. And the CMA has chosen specifically not to do that. And it is very important to see this issue, this November issue of the Linacre Quarterly, as not any sense making an official statement from the Catholic Medical Association. We invited papers to be written on the topic so that the discussion could continue, and we attempted to make our selection of papers very careful and very clear in terms of papers that are scholarly, as well as some papers that just present some experiences of Catholic physicians that have left questions in their minds. But this is by no means a kind of an official statement of the Catholic Medical Association.
So as a final question, what takeaways would you like to leave with listeners? What do you think is important to the lay listener on this topic?
Well, stay tuned. This is a very important issue, not only for physicians, those of us in healthcare, but it reaches into the society, it reaches into families afflicted and affected by tragedies and circumstances that leave a loved one in situations of life support, life-sustaining therapy. So stay tuned. It's an unsettled issue, I would say, for sure, as we've heard. And I guess that's it.
Deacon John, Sister Mary Diana, thank you very much for being with us and talking about this incredibly important topic. We'll be back with the answer to the trivia question on this episode of Dr. Doctor after the break.
And we're back with Dr. Doctor and the answer to the trivia question.
Yes, so the main purpose, as we're going to demonstrate in the answer, for declaring brain death is to get fresh organs for transplantation. So part one of our two-part question was, how many organ transplants were performed in the U.S. in 2018? The answer? If you were plus or minus 5,000, I think you're excellent. The answer was 36,528. But what's more fascinating is that during the break, Dr. Mullally strove to dive deeper into this. And what did he find?
I'm just a number cruncher, Tom. That's all I do. Crunching the numbers.
And what numbers did you crunch?
If you look at all the deaths in America in 2017 and you do 2%, you get about 43,600 deaths. And we know between 1% and 2% are brain deaths. So we're looking at, 36,000 organ transplantations. That's pretty much, I would say, all brain deaths.
Yep.
So there's not a lot of brain deaths who are not leading to a transplantation.
Right. So the numbers would suggest that the vast majority, if not all of the brain deaths are now, maybe this was also used to take somebody off of a ventilator. That
Right.
could be another purpose. But many of those patients, they were after their organs.
Yeah.
And this is something that really happens. So the second question is, what percentage of Americans are signed up to be organ donors? So, Andrew, looking at that answer, is it higher or lower than you expected?
It is lower than I expected, but that doesn't say much.
Well, the answer is 58%.
58%. Was it higher or lower than you thought?
I didn't know what to expect, honestly, because I've got so many different of my own opinions about it that I guess I was thinking like you would probably be higher.
I know when you go to register for a driver's license, at least when I did, and I've heard stories from others, they kind of, I don't want to say coerce, but they really encourage you to do it. Like, why wouldn't you?
Right. And in countries where you have to opt out instead of opt in, like in the United States, the rate's higher.
Yeah, I can imagine that. That would be...
Because I think the rate would be higher if it was an opt out. That is, you're assumed to be an organ transplant donor unless you decide not to. And then finally, 20% of people die daily waiting for a transplant.
So we do have a big need for transplants too. So you can appreciate, man, if this is something that we can continue doing, people need them.
Thank you again for listening to another episode of Dr. Doctor, the official radio program and podcast of the Catholic Medical Association, brought to you from the studios of Redeemer Radio on the EWTN Global Catholic Radio Network.
Be sure to tune in next week for your appointment with Dr. Doctor, where we will be discussing recent national health care legislation with U.S. Senator Todd Young of Indiana, a member of the Senate Finance Committee and Health Subcommittee that oversees Medicare.
This is Dr. Tom McGovern.
And Dr. Andrew Mullally signing off until your next dose of Dr. Doctor.
Dr. Doctor is the official radio program of the Catholic Medical Association, whose members are dedicated to upholding the principles of the Catholic faith in the science and practice of medicine. The views expressed on Dr. Doctor do not necessarily represent those of your co-hosts or the Catholic Medical Association. Find our past episodes and keep up with the latest from Dr. Doctor by subscribing in your favorite podcast app and following us on Facebook. Get links to follow and subscribe or submit a question for our doctors by texting the word DOCTOR to the Holy Cross College text line at 260-436-9598 or visit Redeemer